Hi, my name is Sarah Bro, and I am going to do a brief talk on intermittent self-catheterization. I'm a community care nurse with Coloplast. I have been for the last 10 months. My background would be, for the last 20 years, I've been a staff nurse in the urology department in Tala Hospital. So I'm just going to start with a brief introduction to intermittent self-catheterization. So clean intermittent catheterization was introduced by Lapidist, an American urologist in the 1970s, where the simple, clean technique of catheterization could be used instead of an aseptic technique. Intermittent self-catheterization is simply a term to describe the process of regular catheterization to remove urine from the bladder. So why do we teach ISC? We teach ISC to improve bladder health, lower the risk of urinary complications, and allow a greater sense of freedom, control, and independence and quality of life. So intermittent self-catheterization is accepted as the gold standard to manage bladder issues. So the goals of ISC: complete drainage of the bladder at regular intervals, promote independence and dignity for individuals, prevention of overdistension of the bladder and urinary tract. And as a guide, an adult has a bladder capacity of about 400 mils. Prevention of urinary incontinence between catheterizations, minimize urinary tract infections, and stricture dilation. I'm just going to do a brief introduction of the anatomy of the kidneys, urethra, and bladders, ureters, bladder, and urethra. So you've two kidneys. The kidney on the left is slightly higher than the kidney on the right. And then from each kidney, there's a tube draining into the bladder, the ureters. A bladder is a collapsible muscular sac with 3 openings, 2 for the ureters coming from the kidneys and 1 for the urethras where we pee or void from. Its main function are to collect urine from the kidneys, to store the urine, and then to release the urine, i.e. to void or to pee. It is the size and shape of a pear, and as we said, it can store about 400 to 600 mil. Then the male anatomy. So the male urethra, which is the tube where we pee out of, is 15 to 20 centimeters long. It's shaped like an S. The urethra runs from the bladder neck to the tip of the penis. The prostate lies below the bladder neck. The length of the urethra allows that men are less likely to get urinary tract infections. And it has just 4 distinct areas: the prostatic, the membranous, the bulbar, and the penile urethra. Men face a number of anatomical and clinical challenges performing ISC. A, because how fragile the mucosa is, and it's the innermost layer of the urethra and bladder. It's composed of thin layers of epithelial cells, and it can be vulnerable to urethral trauma. And then the posterior urethra is the most problematic area because of passage issues. Female anatomy. The female urethra is straight and 3.5 centimeters long. It runs from the bladder to a point between the vagina and the clitoris called the urethral orifice. This is where we pee out of. Women are more likely to get urinary tract infections because of the closeness to the bowel. And when we are cleaning ourselves, we should always clean from front to back and not back to front. So I'm just going to give you a brief outline of spinal cord injury. So the definition is damage to the nerves in the spinal cord that send and receive messages to and from the rest of the body. This can be temporary or permanent. So traumatic spinal cord injuries are caused by falls, motor vehicle accidents, sports-related accidents, and acts of violence. And non-traumatic spinal cord injuries can be caused by cancer compressing the spinal cord, spina bifida, MS, effects of drugs, toxins, or radiation, and then embolism obstructing blood supply. And then how does a spinal cord injury affect the bladder? So the muscles and the nerves of the urinary system work together to hold and release urine at the right time. Nerves carry messages between the bladder and the spinal cord and the brain. The messages tell the muscles of the bladder to either tighten or release. When a patient has had a spinal cord injury, this is where the nerves don't work the way they should and they have been damaged. And this is called a neurogenic bladder. So symptoms of a neurogenic bladder are urinary tract infection, kidney stones, bladder stones, urinary incontinence, dribbling, loss of feeling the bladder is full, which is urinary retention, small capacity bladder, frequency, and urgency. So the impact of a spinal, so how does a spinal cord injury actually affect the bladder? So there's two ways it can affect a bladder. It can affect the bladder from by causing a reflex bladder. This is failure to store urine where you can be totally incontinent. It's also called an overactive or hyperreflexive bladder. Usually occurs when the injury is above T12, empties automatically, as I said, no control. Symptoms are totally incontinent urinary tract infections. So there are several ways of treating a reflex bladder, and that's with the use of Botox or with medication using antispasmodics or anticholinergics. And the second way a spinal cord injury affects the bladder is called a flaccid bladder or an underactive bladder. This is also called a hypotonic bladder. A failure to empty the urine usually occurs when the injury is below T12. The bladder becomes overstretched and damaged, no detrusor contraction or no sensation. And symptoms can include leakage and discomfort. Intermittent self-catheterization is a treatment used in a flaccid bladder. You also can insert a urinary catheter or a suprapubic catheter. So advantages of intermittent self-catheterization: improves independence and body image, reduces risk of urethral trauma and urinary tract infections associated with indwelling catheters, maintains normal bladder and kidney function, and patients can remain sexually active and take more responsibility for their own care. Disadvantages of intermittent self-catheterization: physical disabilities, poor eyesight and or manual dexterity limited the ability to perform intermittent self-catheterization. Psychological barriers to using the techniques such as fear of pain, poor understanding of the anatomy of the urinary tract, small bladder capacity would require frequent catheterization, episodes of incontinence between doing ISC, and time taken to teach and gain confidence to perform ISC. So cautions in relation to performing ISC. So assessment of every individual is very important. Patients should have good vision, good power in their hands to perform ISC, and to understand why they're doing it as well. Mobility can be an issue as well, and there is plenty of techniques to teach patients who are wheelchair bound to perform ISC. Psychological concerns: previous false passage, strictures or infection, post-prostate surgery, bladder neck incision, or urethral surgery, those with an AMS or artificial prosthetic stent, artificial prosthesis. It can be difficult to perform ISC. And then if females with obstructing vaginal prolapse, it can be really difficult to perform ISC and a small capacity bladder. And then contraindications to intermittent self-catheterization is priapism in men, which is permanent erection, injury or tumor in the urethra or penis, capacity issues, and care support. Catheter considerations. So when I'm teaching a patient catheterization, as well as assessing their vision, the power in their hands, their mobility, their ability to understand why they're doing it, it's also very important to look at the types of catheters available for someone. The value of previous user feedback is also very important. And then to look at an individual's lifestyle needs, how active they are, can you stand up, do you have to do catheterizations in the chair only, clinical evidence-based quality assurance and support. And then it is important that we use catheters have infection-reducing properties, for example, no-touch catheters. And there's plenty of catheters on the market that you can use without touching. Additional features such as integral drainage bags or sets. These can be very handy for patients who have limited access to toilets, or as well as going on holidays where it's very difficult to find toilets, and user-friendly aspects of design. So there's plenty of catheters available to try, standard compact set, and then there's hydrophilic and pre-prepared catheters. So the size, so in pediatric patients, the size we normally stick from a 6 to a size 10 catheter. Females always, we use a smaller catheter, size 10 to size 14, and the male from around size 12 to size 16 are usually suitable for men. Standard length catheter may be better for obese or pregnant ladies. Always use the smallest size possible to reduce urethral trauma and discomfort. And when performing self-dilatation, a size 18 can be used. There are plenty of catheter aids available to help with patients who have reduced dexterity and mobility issues. We have actually in Coloplast, we've just released a new mirror which we will be rolling out, which attaches to the leg for female users in a wheelchair. It can aid with insertion of the catheter. So teaching ISC. So when I teach ISC, I usually sit down with an individual and explain why they have to do ISC and go through their actual bladder problem, and then go through what risks are associated with intermittent self-catheterization, such as infection and bleeding. And then it's very important to go through the benefits of ISC. Fluid intake is also very important. Make sure they're drinking plenty, but to reduce caffeine and fizzy drinks, especially later in the evening. Drinking very late at night can cause incontinence between catheterizations. It's important to go through a full explanation of their anatomy, go through the appropriate catheter with the patient and select the catheter with the patient. Hygiene is extremely important. To make sure the patient is washing their hands before and afterwards, and genital hygiene, disposing and obtaining catheters, never reusing catheters, potential problems that they may experience while catheterization, and also positions to do catheterization for male and female. So there are many different types of positions that you can, there's many positions that for male and female. Obviously the male anatomy allows it to be much easier to catheterization, so it can take a little bit longer for females to learn how to, what is the best position so that they're comfortable catheterizing themselves. So I'm just going to quickly go through the actual male technique of catheterization. So if I was teaching a patient, I would always get them to void beforehand, normally, if they can, and that's to establish how much they're holding into the bladder. But if a person is a user and is doing self-catheterization for quite a while, they don't void at all, there's no need to go through this. So preparation is the key. Have your catheter ready. Wash your hands. Dry excess urine, wipe the tip of the penis. Now you can use a water wipe, or you can just use a flannel and water just to clean the tip of the penis. If you haven't been circumcised, it's important to pull back the foreskin and clean around the tip of the penis as well. Then to hold the penis upright at 90 degrees with the non-dominant hand. Visualize the meatus, which is the opening at the top of the penis. Guide the catheter with the dominant hand into the meatus or into the tip of the penis. Slowly insert the catheter into the penis. Now you might feel a resistance when most of the catheter has gone in on the men. It's just usually at the prostate and where the muscle releases before you insert the catheter into the bladder. So if you find it very difficult to insert it beyond this point, if you just cough and slowly push, the catheter should slip into the bladder quite easily. You'll know when you're in the bladder when you get a urine flow. Now this is where you just should lower the penis down, so with gravity you allow the bladder to drain. You allow the bladder to drain until the urine stops, and then I would withdraw about an inch to make sure you drain the base of the bladder, and then slowly pull out the catheter and you dispose of it. You never reuse the catheter. Female catheter, the same again. If you were teaching a patient, you would always get them to empty their bladder first. But if you're an established ISC user and you don't void at all, that it's important then that you clean from front to back. Obviously, so first of all, wash your hands. Get into a position that's comfortable for you to perform your catheterization. And with your non-dominant hand, you're going to spread your labia open, which are the two flaps of skin over your urethral opening. You find your urethral opening. Some patients can do this without using a mirror, and some patients need to use a mirror for this procedure as well. So slide catheter slowly into the urethra. If the catheter goes into the vagina by mistake, you discard that catheter and you open a new one. Urine flows, the female water passages is very short, so urine should flow quite quickly. You wait until it stops, and then you pull out the catheter about an inch to empty the base of the bladder. You withdraw the catheter slowly and you dispose of it, and then you wash your hands afterwards. So this is a guide for patients who do pass urine in between catheterizations. Obviously, if you are unable to avoid, you should be passing a catheter 4 to 5 times a day, if not more. And then if you have a residual greater than 500 mils when you pass the catheter, but you're avoiding small amounts in between, you should be doing catheterization about 3 times a day. So this is a guide. Every person is different, and this may need to be adjusted based on your individual assessment. So categorizing away from home, it is important to be prepared that if you're going away or out on a journey, that you do carry several catheters with you. If you haven't got access to hand washing, that you bring bacterial wipes with you. There is a radar key available which gives you access to toilets. Consider a travel certificate which Coloplast have available, and a doctor's letter if you're traveling abroad. Just checking your travel insurance to see, are you covered if anything happens to you abroad. If you're traveling, it would be advisable to carry some product with you on the plane, and then maybe post ahead, or put the rest of the product into your luggage. Just check your product storage conditions at temperatures that should be stored, and always, when you're away, have a good fluid intake, especially in hot countries. Drink bottled water. It's safer to drink bottled water. So intermittent self-catheterization in pregnancy. It is safe to use ISC to do catheterization during pregnancy, although there are some areas to highlight. Positions used for ISC may have to be adapted because you're pregnant. You may have to use a longer catheter as you get into the later stages of pregnancies. This is because the urethra elongates, and pregnancy often causes an increase in frequency and urgency because of the pressure on the bladder from the baby. Troubleshooting, leakage in between catheters. If there is medication to calm down the bladder, such as antispasmodics, if you are leaking in between catheters, but you also have to look at your fluid intake. Are you drinking way too much? Are you drinking too much caffeine? Caffeine-free coffee and tea are available now on the market. Fizzy drinks always can irritate the bladder as well, which can cause leakage. So these are all considerations to take in. Bleeding. Bleeding can occur. It shouldn't happen, but it can occur, especially in men, because the mucosa or the water passage lining is very sensitive. Bleeding is also a sign of infection. So if this occurs, I would check in with your GP and send in a sample. Difficult insertion. Sometimes it can be difficult to insert a catheter. You might have to downsize the catheter if you find it very difficult to get in, but also to try and just relax. Take a deep breath. If you're finding it difficult to insert, just take it out, take a breath for a few minutes and try again. Sometimes if you have to sit down, for men, to sit down on the toilet rather than standing up, because you can be a little bit more relaxed sitting down. Strictures and false passages can make it really difficult to catheterize. If you have a stricture or a false passage, I would consult a GP, or if you're having difficulty passing urine with a stricture, you'd have to attend an accident and emergency. I wouldn't force a catheter, you will cause too much damage. And then urinary tract infection, which I'm going to go through now in a few minutes as well. So urethral trauma is a potential burden for ISC users. And this can happen because with long-term use of a catheter. 5% of patients are affected by strictures. So strictures is basically a narrowing of the water passage. And most strictures can present after 5 years. Prevalence of false passages increase with the use of long-term catheter use as well. So a false passage is where, when the catheter has been inserted, it has kind of gone into the lining of the water passage and created a little false passage where it won't go any further. So bleeding can be an indication of trauma, and then infection as well can be an indication of trauma. The urine tract infection is only diagnosed when there are bacteria in the urine and the patient has experienced one or more symptoms, including fever, sweating, pain when urinating, increased frequency to urinate, increased urge to urinate, cloudy bloody urine, dark coloured, strong smelling urine, shivering, including muscle spasms, flank pain. Patients should always consult a healthcare provider if they have any of these symptoms. And I would advise that if you have these symptoms, that a sample of urine is sent off to the laboratory. GPs will put you on a broad spectrum antibiotic while waiting for these results, but it is important that you are you know the correct the sensitivities of your urine sample, so you know the correct antibiotics to be put on. Tips to avoid urinary tract infection is maintain good hygiene, hand washing, cleaning the urethral opening, especially in women, always clean from front to back. Regular emptying the bladder completely, so right technique, right catheter option for the patient. Always be prepared and create a routine that works for you. And fluid intake is really important as well. So positive impacts on quality of life of a patient. Doing ISC improves urinary symptoms, unbroken sleep, independent, looking after your bladder health, more self-confidence, yes, less urine incontinence, normal sex life, less local periurethral infection, febrile episodes, stones, or deterioration of renal failure or kidney failure. Negative impacts, feelings of worry, shock, fear, depression, affects family and social life, can be painful, time consuming and having to watch the time to perform ISC, may take time to adapt to daily life. Performing ISC does take a while to get used to. It doesn't happen in a day or a week. And many patients we would have to revisit and even just to boost their confidence and go through issues that they're having. It does take time to establish a proper routine. So a set catheter. So a set catheter is a catheter that has a bag on the end of it. Set catheters, I use set catheters all the time for training patients to do intermittent self-catheterization. And then if I feel they're confident enough, I would move on to a more discreet catheter. But set catheters I find A, for teaching patients, but B, for patients who have less mobility, who have mobility issues. A set catheter is really beneficial to them. So it means that you can perform ISC in a wheelchair. There's less transfers, less stress on joints and less skin damage. It makes catheterization easier for those who have manual dexterity issues. Can be used when there are no suitable toilet facilities or access. Avoids spillage on clothes. Makes catheterization easier for those, as I said, with mobility issues, and reduces the fear of accidents because the bag will catch the urine. Summing up, each patient is different, and it's very important when a healthcare provider is teaching a patient to perform SIC to assess them properly, to establish what their needs are, what their concerns are. We have a wide range of catheters in Coloplast, and we have a catheter to suit every individual's needs. Referral process to Coloplast, direct from urology, neurology, acute hospital environment, acute public and private, from the community, Spinal Bishop Hydrocephalus Ireland, Spinal Injuries Ireland, the MS Society, We network with the territory managers in the hospitals with regular meetings, updating new stock. And we also do educational sessions, online teams, conferences, as we are doing today. We have a large nursing team and a sales team. So in Ireland, the nursing team consists of a nurse manager. We have 5 nurses in the south and 2 in the north, and our director of nursing is in the UK. What do? We look after patients with ISC needs, stoma needs, and peristeen needs. It's a complete nursing role and patient focused. And as I said, we have a vast sales team as well who work together with the nursing team to provide an efficient and effective service. We see any patient. You do not have to be on a Coloplast product to be seen. This is a free service. And we do provide skills training as well for healthcare providers.